the term developmental, it refers to the fact that the hip dysplasia or the dislocation can happen at multiple points in time, whether it's during the embryonic period, the fetal period, during infancy, or in childhood. And then in terms of dysplasia, it's also a disease spectrum. It can refer to either the acetabulum or the femoral head, and either delayed ossification of the femoral head or actual subluxation and dislocation. So in terms of dysplasia, we want to think about both sides of the hip, the femur and the acetabulum. And when we think about the femoral head, we want to think about what it's doing at rest. Is it located in the joint? Is it subluxated or is it dislocated? And then if it is in the joint, is it subluxatable or dislocatable? And then if it's dislocated, is it relocatable or reducible or irreducible? And then we have to think about the acetabular or cup component in the fact that is the socket shallower or more vertical than normal. Two other terms that we should know about are the terms of teratologic hip dislocation versus a typical hip dislocation. And so a teratologic hip generally occurs prenatally. It's fairly rare. And by definition, it's irreducible by closed means, and it's associated with other syndromes, the most common of which are arthrogryposis and spina bifida. In a typical hip, it's generally found in an otherwise normally developing child, and the dislocation occurs anywhere in that time spectrum, and it's usually reducible by closed means, if found early. When we look at why DDH occurs, or first we'll look at the normal development of the hip, the acetabulum and the femoral head originate from the same cells, and so it's one big island of cells to begin with. And then at 7 weeks, there's a cleft that develops between the femoral head and the acetabulum. And by 8 weeks, the cartilage of the ilium, ischium, and pubis form the triradiate cartilage. By 11 weeks, the hip joint is fully formed, and that is the earliest time a dislocation can develop. Oops. And then by 16 weeks, you have development of the vasculature and musculature, and you get active motion. And just as a reminder, the triradiate cartilage is the confluence of the ilium, the ischium, and the pubis. So at birth, the entire proximal aspect of the femur is cartilaginous. And then around 4 to 7 months, the ossification starts at the proximal femur. And you have 3 main growth centers at the proximal femur, the head of the femur, the greater trochanter, and then the isthmus in between. So the reason this is relevant to DDH is that the hip must be in the joint for both the acetabulum and the proximal femur to develop normally. And that favorable remodeling occurs when the femoral head is sitting nicely concentrically reduced in the acetabulum. And the remodeling potential for the hip is highest in the neonatal period, but does continue, the majority of which is up to the age of 4, but some remodeling occurs up to the age of 8. So who does DDH happen to, or how common is it? The overall incidence of dislocation is approximately 1 in 1,000 live births, and dysplasia itself is more common. It's about 1 to 3 in 100. It typically affects female babies more than males. There's also an association with the hip, the side of the hip, the laterality. Most commonly, it's the left hip, and about 20% are bilateral, and the remainder of it is the right side. There's also an association with ethnicity in terms of it being more frequent in certain populations, and we'll talk about why that might be in a few moments. In terms of what causes hip dysplasia, there's multiple factors. There's known familial associations, mechanical factors, possible hormonal factors, and postnatal factors. So back in the 70s, there was a large study done that looked at familial associations of DDH. And they came up with these percentages in terms of risks for subsequent children. So if you have one child that's affected, the chance of having a second child that has DDH is about 6%. If you have one parent, it's about 12%. If you have a parent and a child, it goes up higher, 36%. And then if you're a twin, it's also around the same. So that's why family history is an important risk factor for DDH. It's also thought to be, or considered to be, a result of mechanical forces in terms of it being considered part of a crowding or packaging disorder. So the theories are that the reason that the left hip is more commonly involved than the right, it's adducted against the maternal sacrum. Firstborns too have theoretically they have less space in the uterus. Oligohydramnios gives the baby less space. And a breech presentation positions the hip at risk for DDH as well. Other associated positional anomalies are also congenital muscular scoliosis, which occurs at a rate of about 15 to 20% in children who have DDH, and also metatarsus adductus, which occurs in about 1.5 to 10%. So those are associated conditions that we should look for when assessing a child with DDH. In the past, there have been theories as to why girls are more affected than boys. And one of those theories is that there are still maternal estrogens in the system that might induce laxity in the hip capsule. And because female babies have receptors for these, there's a thought that perhaps this might be a reason. What we do know for sure is the postnatal environment does influence hip dysplasia. So the reason that there might have been an association with ethnicities is because traditionally, the swaddling or cradle board type of the use of a cradle board in Native American populations has shown a higher risk in those populations. And that's because the hip is extended and adducted, and the baby's not allowed to freely move into flexion and abduction. And so to test this theory, there have been studies that were done in animals where they were splinted in extension, newborns, and those rats or pigs that were splinted in extension developed hip dysplasia. So in certain cultures, such as in Africa, where children are not swaddled and are mostly carried around in this position on a mother's back, the incidence is much lower. So in general, we do discourage swaddling, and it's better to either carry your infant on your back if you can, or to use a sleep sack. So in summary, risk factors are breech, female, firstborn, family history, or anything that decreases space for the baby in the uterus. We just have to remember that there's associated packaging disorders. So what happens when there is laxity in the hip joint and the hip starts to slide out of the joint? So it starts off with laxity of the hip capsule, and because the femoral head rises superior and laterally, the anterolateral rim of the acetabulum starts to flatten. The labrum might invert, and you may get this ridge of hypertrophied cartilage on the superior, inferior, and posterior aspect of the acetabulum that we call the neolimbus. But at this point, these changes are early, and the hip is usually reducible, and the changes are usually reversible. Later on, what happens is that there's a change in the structure of the tissues, both inside the hip joint and outside the hip joint. So the pulvinar, which is the fibrofatty tissue that sits right in the hip joint here, starts to become thickened. The ligamentum teres, which connects the femoral head to the acetabulum, also can become thickened. We were talking about the inverted limbus and labrum. There's a transverse acetabular ligament down here. And then the joint capsule itself can be constricted. And what you don't see here is the psoas muscle, which is the hip flexor, comes across and can also constrict the capsule. Later on, without the remodeling forces of the femoral head being in the acetabulum becomes more shallow and vertical, and ossification of the femoral head is further. And so the femoral head also becomes flattened and aspherical. And then over time, you get soft tissue contractures. And if the femoral head is sitting way up above the natural acetabulum, it can start to form a false acetabulum in the ileum. And then this, of course, leads to degenerative joint disease. And so, what's the natural history of DDH? So, way back when in the 60s, Barlow, for whom the Barlow test is named, noted that about 88% of Barlow positive hips become stable in the first 2 months without treatment, and about 60% stabilize within the first week. But if you have a false acetabulum, so if it's a long-standing hip dislocation, you have a worse prognosis. If it's bilateral, then you may end up with hyperlordosis, low back pain. And if it's unilateral, of course, it leads to a leg length discrepancy, which can then lead to knee pain, scoliosis, or gait disturbance. In terms of long-term outcomes, it's highly variable. So a study in 2010 looked at, well, when do you become symptomatic if you have untreated dysplasia or dislocation? So if you purely have acetabular dysplasia, you might become symptomatic around age 34. If it's a low dislocation, it's a little bit earlier. If it's a high dislocation with a false acetabulum, that's the earliest. Or if it's a high dislocation without a false acetabulum, then you have a better chance of having more years without pain. And so DDH is thought to be a precursor, or is a known precursor of hip osteoarthritis. And so this study looked at which variables would be more strongly associated with osteoarthritis. And it found that the acetabular index, which indicates how well the femoral head is covered by the acetabulum, is the most strongly associated, and that's a sign of acetabular dysplasia. And then when they looked at populations of people who were having total hips above the age of 40, approximately 26 of those had untreated DDH or residual DDH. And so how do you diagnose DDH when you're examining a baby in the NICU or in the clinic or in your office? So key points on history to remember are your risk factors. So those are your firstborn, female, breech babies who have a family history, especially a first-degree relative, or if they have some sort of packaging issue, like being large for gestational age or oligohydramnios. You also want to make sure that this is not associated with other conditions, such as genetic, congenital, or neurologic conditions. And so you do want to take a thorough history and do a thorough physical exam to rule out the associated conditions. On physical exam, you do want to do a full head-to-toe exam, including a spine and a neurologic exam, and you want to also look for those associated packaging issues. And then you want to do a focused hip examination. So when we talk about the focused hip examination, there's a few maneuvers that we always do. The first is called the Ortolani maneuver, and this is when the hip at rest is out of the joint, and you're trying to reduce it. So it's a dislocated hip that is reducible. And so here you're flexing the hip to 90 degrees, you're putting your thumb on the inside of the thigh, your fingers on the greater trochanter, and you're going to abduct the hip, but your fingers are trying to lift the greater trochanter and therefore the femoral head over the posterior rim of the acetabulum, and you're trying to reduce the hip. The other test that we do is the Barlow test. And this is a hip that's in joint at rest, and you're seeing if you can subluxate it or dislocate it. Okay? So it's dislocatable, and then of course it's reducible, because at rest it's in joint. So you flex the hip to 90, you adduct your thigh, and then you apply a posteriorly directed force to see if you can move that femoral head out of the joint posteriorly. These tests are really only reliable early on in life. So after 3 to 4 months, you may not get a positive Barlow or Ortolani test due to soft tissue tension and increased muscle tone. If you have an Ortolani negative hip, that could mean, of course, that you have irreducible hips, but you don't want to miss a bilateral dislocation. So it might feel very symmetric. You might not even notice that the hip is out because it's bilateral. So you should always be aware that bilaterality can make a diagnosis a little bit more difficult. So, in terms of what else you can test on the physical exam. This is the Galeazzi sign, where you're looking for an apparent leg length difference in the length of the femur. And so you place the baby supine with the hips and knees flexed, and you're looking for femoral shortening. And that's because if the hip is dislocated, it's sitting more posteriorly, it's going to appear shorter. The thigh on that side is going to appear shorter than the other side. One of the most reliable findings is limited hip abduction. And if you, in an infant, if you find that there's less than 60 degrees of abduction, you should be suspicious. Or if there's asymmetry, that should also make you think that you need to investigate something further. But again, you should be aware of bilaterality. You know, they can be symmetric, but still limited. So symmetry by itself can throw you off. So always make sure you're looking at how much abduction they have as well. People talk about asymmetric skin folds. That can be an indication for a dislocated hip with a leg length discrepancy, but it's not a very reliable sign, because not everybody has perfect symmetric skin folds, especially babies with their increased adipose tissue. The other thing that you can look at is something called a Quisic sign, where you're putting your index finger on the ASIS and your middle finger on the greater trochanter. And then in a dislocated hip, because the greater trochanter is going, and this line should line up with the umbilicus. But in a dislocated hip, because the greater trochanter is going to be riding high, that line is not going to be, it'll be below the umbilicus, okay? Again, it's not as reliable as the other signs, but it is something that you can do to add to your diagnostic toolkit. In older children, the diagnosis might not be as obvious. They might have a limp, they might have hyperlordosis, they may have a waddling gait, they may have a positive Trendelenburg sign on the affected side. So in this picture, the right side is out. So normally when you stand on one leg, your abductors keep your pelvis level. Whereas if you have a dislocated hip, your abductors are not going to be able to do that well, and so your hip drops to the unaffected side, and you compensate by leaning over. So that's your Trendelenburg sign. But if they have bilateral involvement, again, it can be challenging to identify. So what kind of imaging should you get if you suspect TDAH? In infants under the age of 3 to 4 months, an ultrasound is the most effective, and that's because, as we said before, the femoral head doesn't start to ossify until about 4 to 7 months. And this gives you an idea of the morphology of the hip, what the shape of the hip looks like, the position of the femoral head with relationship to the acetabulum, but it also allows you to assess the stability of the hip, and that's a dynamic part of the ultrasound examination. When you stress the hip, you can tell where the femoral head is in relationship to the acetabulum. And so this can be used to confirm your clinical diagnosis and also to follow treatment. The downside of ultrasound is that it's highly operator dependent, and so in an institution, generally it's good to have somebody you rely on who does your ultrasounds for you frequently, so you know what their ultrasounds look like. So when you're looking at a hip ultrasound, at the beginning it can be a bit confusing. So if you think about it as you're looking at the front of the hip, this is the femoral head, this is the femoral head, there's the bony ilium, there's the bony ilium, there's the bony acetabulum on the medial side, okay? And then you start to get the labrum, and then here are the abductors, okay? Now, that's looking at it straight on, but what we do is we flip it on its side and then upside down. So whether it's a left hip or a right hip, here are your abductors again, okay? This is your ilium, this is your bony acetabulum, your femoral head, your labrum, and your cartilaginous acetabulum, okay? And that's how it'll look whether you're looking at a left hip or a right hip. Okay. So, how does the ultrasound help us? Well, it tells us how deep the acetabulum is. And you might see these measures if you ever read an ultrasound report of a hip or look at an ultrasound. So basically, there's something called the alpha angle, where you draw a line right across the ilium, and then you draw a line down the bony acetabulum, and it's that angle. And it tells you how deep the hip is, or how deep the bony acetabulum is. Now that angle normally should be greater than 60 degrees. What's more important really is how well covered the femoral head is. So we want to know how much of the femoral head lies beneath that green line, okay? And so you just do basically a fraction, and you want to make sure that more than 50% of the femoral head is below the ilium line, okay? And that's what's considered normal. So in these pictures, here's the femoral head, here's the ilium, there's the bony acetabulum. So clearly, there's only maybe like 10 or 20% of the head that's covered. So this is a hip that's almost dislocated. And this is a hip here that's completely dislocated. And here you can tell this is the ilium, this is the bony acetabulum, and the acetabulum really isn't that well formed. Here it's more well formed. Here it's very, very shallow. There's really no space for the femoral head to go. Okay. So, who should get an ultrasound? So there's a bit of a difference between Europe and North America. And the American Association of Orthopaedic Surgeons, their guidelines from 2014, have moderate evidence that supports not performing universal ultrasound screening in newborn infants. Universal screening meaning that every single child that's born gets an ultrasound. Okay. What it does support is imaging infants who are under the age of 6 months with one or more risk factors, the most important of which are breech, family history, or if on your clinical exam you feel instability. There's also limited evidence in using an ultrasound to guide your decision to treat a child who has a positive instability exam in terms of when to start bracing. And that's because ultrasounds under the age of 6 weeks can look a little bit shallow. It's normal to have some shallowness. So if your physical exam is normal and they have some shallowness on the ultrasound and they're less than 6 weeks old, that doesn't necessarily mean that they have hip dysplasia. Okay? There's another review that was done in 2013 that demonstrated that universal screening, meaning that every baby gets an ultrasound, increases treatment and doesn't change the difference in the rate of late detected dysplasia or surgery. And then selective ultrasound screening, which is what's done in North America, didn't significantly increase the rate of treatment, but also didn't reduce the rate of late detected dysplasia. So neither screening program is perfect, and it just really seems like it's a regional variation. It's interesting that infants with subluxable hips, so Barlow positive hips but not dislocated hips, or those who have a normal clinical exam but just mild changes on ultrasound, there isn't really clear guidelines as to what to do with those children. And delaying treatment doesn't necessarily increase the risk of further surgery or treatment or need for intervention at that time. So that's where the gray area is in terms of the Barlow positive hips or hips that are stable but have minor ultrasound abnormalities. So what's even further interesting is that there's a subset of children who later on in life present with hip dysplasia who would never have been diagnosed with DDH during infancy. So there's a study done in 2014 that looked at adolescents who are undergoing periacetabular osteotomy for acetabular dysplasia. So these are adolescents who had signs and symptoms of DDH at adolescence, but were not diagnosed with DDH as children. So they looked at risk factors and radiographic measurements, and they found that 85% of them would not have met the screening guidelines. And so what they concluded that our ultrasound screening as it is currently does not really identify those children who might develop dysplasia later on in childhood. And so there's a subset of children that in infancy might have a normal physical exam, might have a normal ultrasound, but go on to develop hip dysplasia. So when children are older, we get x-rays once they're about 4 months or so. And this is an x-ray of a dislocated hip. Oops. So here's the dislocated hip on this side. Here's the acetabulum. And so you can see the size of the femoral head is smaller. That's that delayed ossification. And the way to look at an x-ray objectively is you first draw a line across the triradial cartilage, and that's called Hilgenreiner's line. And then you can draw a line that's vertical, that's just at the edge, the lateral edge of the acetabulum, called Perkins. And generally, the hip that's in joint should be in this medial inferior quadrant. And this obviously isn't. So anything that is not in the medial inferior quadrant is either subluxated or dislocated. Okay. Then the next thing is you look at the angle of the acetabulum, and you want to see how vertical it is compared to this line. So on the normal side, it's much less vertical than on the dislocated side. Okay? And that's because, like we were saying before, the femoral head needs to be in the joint for the acetabulum to develop. And similarly, the femoral ossific nucleus needs to be in the joint to develop. Okay? So the next thing you look at is something called Shenton's line. So you follow a line from the inferior part or medial part of the femoral neck, and it should mostly line up with the obturator foramen. And then of course on this side, that line is broken because the inferior medial part of the femur is now proximal to the obturator foramen. Okay. And then when you're looking for numbers, so what's normal? In a normal hip, the acetabular index should be, by 24 months, should be less than 24 degrees. At birth, a normal acetabular index should be somewhere less than 28 to 30 degrees. Shenton's line should be continuous, and the ossific nucleus should be present and should be mostly symmetrical to the other side. If you don't have a ossific nucleus and you get an x-ray at 4 to 7 months, another classification that is very useful is one that was developed by the International Hip Dysplasia Institute. So what they did is you have your Hilgenreiner's line, you have your Perkins line. And remember, you can't see the femoral head, okay? You can only see the metaphysis. And you draw a line that's 45 degrees to Hilgenreiner's and Perkins. And then you look at where the center of the proximal metaphysis is. And then that gives you a good gauge as to whether, an objective way of saying whether the hip is in joint, whether it's subluxed or dislocated. These are pretty obvious that they're dislocated, but it gives you a better idea to determine if it's actually in joint versus subluxed if you cannot actually see the femoral head. So that's a more objective way of looking at it. If you get an X-ray and you can't see the femoral head. Okay. Once children are older, you can characterize their acetabular dysplasia by the center edge angle. And basically, you just draw a line from the center of the femoral head up vertically, and another line that goes from the center of the femoral head to the lateral aspect of the acetabulum. And in general, 20 degrees is considered abnormal. Less than 20 degrees is considered abnormal. It's not useful if you use it under the age of 5 because the ossific nucleus can ossify in an irregular manner, and it's also poorly reducible because of that fact. So then moving on to treatment. So the principles of treatment are to obtain and maintain a concentric reduction and to provide an optimal environment for the development of the femoral head and acetabulum. And to remember that the earlier the reduction, the greater the remodeling potential. And of course, you want to avoid complications. So who should you treat? So in children who have clinical instability, especially in those who are autoimmune positive, there's no controversy as to whether they should be treated. They should all be treated, okay? And you should start treatment fairly soon after diagnosis. If they're Barlow positive, the majority are still treated immediately. There are some centers that will observe these children, and they'll repeat the clinical exam around 3 to 6 weeks, and then repeat the ultrasound, and then decide if there's still instability, then they'll treat. But for the most part, any unstable hip, whether Barlow positive or Orthopaedic positive, generally is treated. And then in terms of timing, so when should you start treatment? There have been studies that have shown that there's no difference in outcomes if you start treatment prior to 1 month of age or greater than 1 month of age, but you have better outcomes if you do it before 7 weeks. Generally, you're going to be seeing children who are referred to you within the first week of life, and you're starting treatment then. This is what we were talking about earlier. If you have a normal clinical exam, but just minor abnormalities on the ultrasound, there isn't enough evidence to know whether you should just observe these children versus treat them. So that becomes more of a personal decision. And then children who are breech, who at birth have a normal clinical exam and a normal ultrasound, should still be followed because they still have a risk of developing acetabular dysplasia. So in those children, you want to see them back at 6 months with a pelvis X-ray. Okay. So there's various types of treatments that are available. You'll see multiple splints on the market. What we do know is triple diapers or double diapers really don't work. This French cut pillow, which is this, it provides you with some support, but it's not very stable. The Von Rosen splint, which is down here, can be used as long as you know how to mold it and you're holding the hip in the right position and you want to avoid too much pressure on the skin. The Krager Ilfield can be used, especially if the harness fails. It's good to have an option for a rigid orthosis. But the most common is the Pavlik harness. So the Pavlik harness was actually named after Arnold Pavlik, and it's a dynamic splint, so it allows hip motion, and it prevents the position of dislocation. And so the position of dislocation is really adduction and extension. It allows easy diaper care, and so the anterior straps keep the hip in flexion, and the posterior straps limit adduction, so it prevents the hip from getting into that unstable zone. So when you put the straps on, you put the chest straps on first, the shoulder straps, the leg straps, and then you adjust the anterior straps. But when you adjust the anterior straps, you have to be careful not to flex the hip more than about 110 degrees, because then you might pinch off the femoral nerve and cause a femoral nerve palsy. So we always tell parents to make sure their children are extending their knees, and if they're not, for them to call us right away. Okay? The posterior straps give you that safe zone. So the safe zone is the point between maximal abduction that will cause AVN, or avascular necrosis, and the point at which the hip becomes stable in adduction. Okay? And that's what your posterior straps are trying to do. They're trying to keep the hip in that zone of stability without causing a complication. So, if you put a child in a Pavlik harness, you do want to see them back weekly, every week for about the first 3 weeks. 1, to make sure the harness is fitting, there's no complications. 2, to assess the hip position in the harness, because babies grow and sometimes the straps get tight. And 3, to repeat the ultrasound, but you don't want to stress the hip on the ultrasound, because the whole point is you're using the harness to get the hip in the right position and get the hip capsule to tighten around the hip in the right position. So you don't want to add stress to it and then undo what we've done with the harness. Okay? So if you find the hip is reducing and progressing well, then you want to see them back at 6 weeks after you've seen them weekly for 3 weeks. You want to assess their stability and repeat the ultrasound. And then once the stability is achieved, the guidelines for total treatment vary. Some people say you should put them in a harness for at least 6 to 12 weeks after that point of stability. And then once that's achieved, other people will have a weaning program where they decrease the number of hours in the harness. So, once the harness has been discontinued, you're happy with how the hip looks, you want to do a pelvic X-ray at age 6 months and 1 year. And if they're normal, then you continue to follow them to skeletal maturity. usually at age 2, 5, 7, and 12. But if they still have a bit of dysplasia, so the hip is in joint, but the cup is still a bit vertical, you do want to follow that up with some abduction bracing, the rigid brace. And that requires follow-up until the age of 4, because remember we said the maximum remodeling for the hip is up till age 4. And if the acetabulum doesn't remodel by then they will need a pelvic osteotomy. Okay? If the dysplasia resolves, then you follow them to a skeletal maturity on the same schedule as before. So when would you not use a pelvic harness? If the child is older than 6 months, they'll overpower the harness. They're too strong and they're too big. If you have that teratologic hip dislocation, the one where the hip is out and you can't reduce it because they have another syndrome going on, the harness is likely to fail. Or if they have a major neurologic problem or joint stiffness where you know that hip is not going to go in a closed manner. Or if you've tried the pelvic harness and the hip doesn't reduce, the last thing you want to do is to try and jam a hip in that doesn't want to go in. Because then what you'll do is you'll get pelvic harness disease where the head of the femur flattens as you're trying to jam it into the acetabulum because it doesn't want to go. So overall, the pelvic harness works very well. It's a 70 to 95% success rate. Reduction isn't guaranteed, but it's quite a successful treatment. You do need frequent monitoring and adjustments. You do need compliance from the parents, and you want to avoid complications. So when they look at who fails bracing, those kids who develop a femoral nerve palsy are at risk for failure. If you use a static brace rather than a dynamic brace, if you have irreducible hips, obviously, if you start bracing after 7 weeks, if it's a right-sided dislocation, because remember we said left-sided are more common, if it's a completely dislocated hip on ultrasound, or if they're male babies. So it's almost the opposite of the known risk factors for DDH. So what do you do if they fail pelvic harness treatment? So you can try a rigid brace for a week or 2, or you can do a closed reduction. And then if it's not reducible, then you know you've got to do a closed reduction, or possibly an open reduction. So if we talk about closed reductions, we first do something called an arthrogram, where you inject dye into the hip. So what you're trying to see is you want the dye to outline the femoral head, because remember at this point it's still cartilage, you're not going to really see it on the x-ray. So you need the dye to help you decide, is the femoral head actually in joint? And what you're looking for is the dye will outline the femoral head, but if a lot of dye pools here, you know that there's something blocking the hip from going in. The dye should just be a thin line around the entire femoral head, but if there's a big medial pool of dye, then there's something in the hip joint that's not allowing the femoral head to go in. Okay? So that's why we do the medial dye pool test. And in the past we've said, well, you should have a medial dye pool of less than 5 to 7 millimeters. But the fluoroscopy we use doesn't have those measurements on it, so you can't really use that number. So more recently there was a study that said if the medial dye pool is less than 16% of the femoral head, then that's a good sign that you've got a good reduction, because then you're just comparing a percent rather than actual figures. And then of course, if there's a dye pool, you know there's something that's preventing your reduction. So once you've done your arthrogram, you do a closed reduction, you might decide to do an adductor tenotomy to increase that safe zone that we were talking about, that zone of stability. And then you put them in a hip spica in what's called a human position, where you flex their hips to 100 degrees and you abduct them to 45 degrees. This is what the hip spica looks like. And most babies are usually not that happy. And then you do a close reduction X-ray and an MRI or CT to confirm that the hip is still in after the baby wakes up in the hip spica. Okay? The hip spica cast is kept on for 3 months. And most of us will change the spica halfway, but not everyone does that. Some people will keep the spica on for 12 weeks and just do an MRI at the 6 weeks. But no matter what it is, 6 weeks in, you're going to either take them back to the OR, repeat the arthrogram, and put a new spica on, or you're going to get an MRI in the spica. You're going to check them at 6 weeks to make sure the hip is still in and continue for another 6 weeks. So the MRI will confirm that the hip is in joint. And the nice thing about the MRI is you can actually see the femoral head. Because if you do a CT scan, you're not going to see the femoral head because, again, it's not bone at this point. Okay? And the nice thing about the MRI, too, is it doesn't expose the child to unnecessary radiation. They don't require anesthesia because technically the cast will keep their legs immobile. So unless they're moving their whole body, which sometimes happens, your image should be fairly decent on the MRI. So, the major complication of treating hip dysplasia is AVM. So there's a 10% risk in one study when they followed people up about 7 years following close reduction. However, there's another study that found a much higher risk, about 35%. So anywhere from 10 to 35%, which is not insignificant. In the past, people have used something called traction, where they put a little bit of traction on the legs to try and reduce the risk of AVM, but that has not been shown to reduce the risk of AVM. Some people believe that you have to wait until you can see the ossific nucleus before you reduce the hip, so you're not squishing the cartilage when you're doing it. But again, that hasn't borne out in studies. The AVM rate is the same whether you see the ossific nucleus or not. And there's no real difference in terms of the age of reduction, whether you wait until they're a year or not, in terms of AVM rate. So the risk factors for what they found for AVM are if they have unilateral DVH versus bilateral, or if you put them in too much abduction in the hip spica cast, especially if they're under the age of 6 months. So what happens if you can't get a close reduction? Then you have to do an open reduction. And there's two ways to do it. You can either approach the hip anteriorly, right directly in front, or medially through the groin. And then when you do that, you're trying to remove all the blocks to reduction that are in the joint and outside the joint in order for the femoral head to sit in the joint. And then you also put them in a hip spica, and then you do your post-reduction MRI, and then keep the spica on anywhere from 6 to 12 weeks. After that, generally, most people will transition from a spica to an abduction splint for another 3 to 6 months. So, which should you do? Should you approach the hip through the groin, or should you just go directly anteriorly? In younger children, the medial approach is more commonly used, but the caution there is the medial circumflex femoral artery, which supplies blood supply to the head of the femur, is in your field. And so, there's two ways of doing it. One is to go in between the pectineus and the vessels, and the next is to have a little bit of a buffer and go between the pectineus and the adductor brevis and get into the hip joint that way. In the past, it was thought that there was a higher risk of AVM with the medial approach, but more recent studies have shown that the risk is approximately the same, about 18 to 19%, whether you do a medial approach versus an anterior approach. The downside of doing it this way is you can't really get to the capsule to tighten it if you want to, and if they're older, you can't get to the pelvis to do a pelvic osteotomy if they need. So the anterior approach can be used traditionally about the age of 1, but you can do it in younger children. And this allows you, so here you are, at the anterior part of the hip, you're between your tensor fasciae lata and your sartorius. Okay, and now you're down on the hip joint, and you can open the hip joint up, clean out all your blocks to reduction, but then with your sutures and the way that you've cut the hip joint, you can then tighten the hip joint, and that's what a capsulorrhaphy is. It's tightening the hip joint, holding the hip in place, which you can do through this anterior approach. If they're a little bit older and the hip has been out of joint for some period of time, then when you bring the femur down into the acetabulum, there might be a lot of tension because that femur has been sitting way high up in the pelvis. And if there is a lot of tension when you try and do the reduction, you might actually need to take a chunk of the femoral shaft out. You might need to shorten the femur in order to get it to sit there without any tension. Okay, and that's done through a separate incision. And at the same time, if you feel like they're anteverted too much, which is rare, but it can happen, then you can derotate the femur at the same time. Again, if they're older and they have residual acetabular dysplasia, then they might need a pelvic osteotomy. And there's two commonly types that are done. One is a Salter osteotomy, where you basically are cutting the bone, the pelvic bone, from anterior to posterior, and then you're tilting it down anterolaterally, and you stick a bit of bone graft that you take from your child's iliac crest, and you put it in there and secure it with pins to increase the anterolateral coverage. You can also do either a Pemberton or Vega osteotomy, where the difference is you're coming from anterior to posterior, but you're leaving a posterior hinge, and then you're using bone graft. But same thing, you're tilting the roof of the acetabulum down anterolaterally. Okay? So you're making up for the acetabular dysplasia that they have. So, in summary, DDH is a dynamic spectrum of diseases. The goal of treatment is really to prevent early hip osteoarthritis. You want to remember what your risk factors are, key points on your physical exam. Know that the ultrasound should be done early on, x-rays later on. And the first line of treatment for a typical DDH is a Padlock harness. And this allows the hip dysplasia to remodel. You want to confirm your reduction on ultrasound, but be aware of BVN. But it is a very successful treatment. And remember that if it fails, you can try an abduction brace for a week or two. But if it doesn't reduce, you do need to move on to a closed reduction. And the closed reduction includes the arthrogram, the reduction, and the hip spica. And then if they fail the closed reduction, they have to have an open reduction, with or without a femoral osteotomy, with or without a pelvic osteotomy if they're older. And that's it.